Monday morning, 10 past 7, in a town with no CT scanner, a 74-year-old man walks, badly, through your emergency department door, held up by his wife.
His right arm will not grip. His words are slurred. She says he was normal when they went to bed. Give me the first 3 numbers you want.
Glucose, blood pressure, and the clock. A finger prick glucose first, because hypoglycemia is the stroke mimic that reverses in 60 seconds, then a blood pressure, then the single most important number in stroke medicine.
Which is not his door time.
Correct. It is his last known well time, not when he arrived, not when his wife found him at 10 to 7. When was he last witnessed? Normal. She says they watched the news together. He made her a cup of tea at 11:15 and his speech was fine. He woke with the deficit. So his stroke happened somewhere inside 8.5 hours of sleep.
Say why that one number reorganizes everything.
Because every reperfusion decision in stroke is anchored to last known well, not to arrival. A patient who fronts up 90 minutes after onset is a different clinical entity from the same patient who woke up with it. Alistair here is roughly 8.4 hours from last known well at his door. That number is already outside the standard thrombolysis window before anyone has lifted a stethoscope.
Welcome to Stamps Daily. It is Monday the 24th of August, day 81 of the countdown, 11.5 weeks to the exam. Foundation phase, and today is a 5-star topic the handbook does not shy away from: acute stroke in a town that cannot image the brain.
One scenario worked end to end. The hyperacute assessment, the thrombolysis knowledge the examiners will expect you to carry in your head, the telestroke and retrieval choreography, and the interim management that is the real fellowship answer when the aircraft is hours away.
Plus 2 embedded reviews. A 7-day review of the mental health crisis episode from day 88, this time rebuilt on Victorian law rather than Queensland's, and a next day review of yesterday's bronchiolitis episode, because oxygen thresholds fade fast.
We flagged at the top, this is independent exam preparation, not endorsed by the college, and we do not predict stations. We build the reasoning substrate.
Back to the bedside. Alistair, 74, smoker of 45 pack years, type 2 diabetes on metformin, hypertension on perindopril and indapamide, no atrial fibrillation that anyone knows about, no anticoagulant. Blood pressure in the clinic usually runs 150 to 160 over 85. What does your examination actually consist of?
A structured neuro-examination in the shape of the stroke scales, even though I never need to say the acronym aloud. Level of consciousness, gaze, visual fields, facial movement, motor power in arms and legs, sensation, and critically language versus speech. Dysarthria is a mechanical problem. Dysphasia is a cortical problem. They localize differently, and the examiners listen for you separating them.
And what do you find?
He is GCS 15, right facial droop, right arm power 3 out of 5, right leg 4 out of 5, slurred but fluent speech, no word finding difficulty, follows commands, glucose 7.8, which kills the mimic, vital signs, heart rate 88 and regular, blood pressure 178 over 94, saturations 96% in air, a febrile, rough severity score, about 9, a moderate stroke with a worsening right arm.
Heart rate regular. Why did you say that with emphasis?
Because the cardiac rhythm is a fork in the road. Atrial fibrillation found now converts this from large vessel atheroma to cardioembolic disease, changes the secondary prevention from antiplatelets to anticoagulation, and explains maybe a quarter of ischemic strokes at his age. A 12-lead ECG sits in the first 10 minutes of care, and I would flag a period of prolonged rhythm monitoring downstream if the first trace is silent.
Before we chase reperfusion, earn the diagnosis. What else does sudden unilateral weakness with slurred speech turn out to be?
The dangerous list and the common list overlap less than people think. Hypoglycemia, checked and excluded. A seizure with a post-ictal Todd's palsy, which can mimic a complete stroke and resolves within 48 hours, so any witnessed convulsion or confusion matters in the history. A complicated migraine, though his deficit came on asleep and without headache. A space-occupying lesion presenting acutely, usually with a more subacute run-up. A functional weakness which is inconsistent on repeated testing.
And the one you cannot exclude by examination at all.
Haemorrhage. And that is the axis the whole scenario turns on. Roughly 1 in 7 acute stroke presentations is a bleed. The examination cannot separate it. The history cannot separate it. Only imaging separates it. And this town owns a plain X-ray machine and nothing else. No CT, no MRI. The nearest scanner is 295 kilometers away at the regional hospital.
Hold that thought, because I want the thrombolysis knowledge first. If you were standing next to a CT scanner right now, what would the current Australian guidelines let you do? Exact drugs, exact doses, exact windows.
The living guidelines from the Stroke Foundation, updated September 2025, for a potentially disabling ischemic stroke within 4.5 hours of onset, intravenous tenecteplase is now first line, 0.25 milligrams per kilogram, maximum 25 milligrams, single bolus. If tenecteplase is unavailable, alteplase at 0.9 milligrams per kilogram, maximum 90 milligrams, 10% as a bolus over a minute and the rest infused over an hour.
Beyond 4.5 hours?
There is an extended pathway, but it is conditional on imaging selection. Up to 9 hours from last known well, tenecteplase or alteplase can be given if perfusion imaging shows a mismatch, meaning salvageable brain, and for the wake-up stroke specifically, the clock can start at the midpoint of sleep. Alistair went to bed around 10:45 and woke at 10 to 7. Midpoint would be roughly 3 in the morning, which puts him about 4 hours from a notional onset at his door.
So a candidate after all, if only he could be imaged and selected.
In theory, the wake-up pathway keeps a door ajar, but only through a scanner he does not have. And 2 newer statements matter. The 2025 update recommends against thrombolizing a non-disabling stroke at all. The benefit sits in preventing disability, not in treating a numb thumb. And there is a new consensus statement on reversing dabigatran with idarucizumab before thrombolysis where it is time critically available. Alistair is on no anticoagulant, so his only barrier is time and imaging.
Now the rural examiner's actual question. You are standing in a town with no CT. A man with 8 hours of evolving hematopoiesis is in front of you. Do you give a thrombolytic?
No, and I say that without apology. Thrombolysis without prior imaging to exclude haemorrhage is not rural heroism, it is an uncontrolled gamble with a 1 in 7 chance of pouring clotbuster into a bleed. The fellowship answer is systems, not bravado. My job is to get him to a scanner fast, keep him physiologically intact on the way, and have the conversation with the specialist who can see what I cannot.
Who do you call on what number, saying what?
2 calls, in parallel, within 15 minutes of arrival. First, the Regional Stroke Network. Victoria runs a 24/7 Telestroke service through Ambulance Victoria that connects 19 regional hospitals plus 3 in Tasmania to a stroke consultant by video, and it has measurably raised thrombolysis rates and cut door-to-needle times in the bush. Our scenario town is not itself a telestroke site, so my pathway is the regional hospital's stroke team, structured as ISBAR, who he is, last known well 1045, deficit and severity, vitals, glucose, medications, allergies, anticoagulant status nil.
Second call.
Adult Retrieval Victoria, the coordination line for aeromedical transfer. The aircraft sits 900 kilometers away, 90 minutes of flight time, but activation to wheels down at my door is realistically 3 hours. I book at 7:35 and I say the clinical picture in one line so the receiving team can pre-alert their CT and their stroke crew before he lands.
While you organize all this, the nurse rechecks his blood pressure and gets 196/102. She asks you to lower it. Do you?
No, and the reasoning is worth saying slowly because it is a favorite Viva. 2 thresholds exist. If he were about to receive a thrombolytic, I would need his pressure under 185 systolic and 110 diastolic before treatment, and I would hold it there for 24 hours after. He is not receiving one here, so the second threshold governs. Only pressures above 220/120 in the non-reperfusion ischemic stroke get treated, and then cautiously, dropping no more than about 20% across the first day, because aggressive lowering strangles the penumbra's collateral flow.
196 is under 220, so you watch.
I watch, and I chart 15-minute blood pressures while the pressure runs above 160, and I name the trigger in the notes. Treat only if he crosses 220 systolic or 120 diastolic, and then with something like intravenous labetalol titrated, in discussion with the retrieval clinician. Deciding the threshold in advance is what stops a busy mid-morning from becoming an accidental overcorrection.
His repeat severity score is 11. The right arm has drifted from 3 out of 5 to 2. Does a rising score change your plan?
It changes 2 things. Clinically, evolution tells me this is an active process, which strengthens the case for the fastest possible transfer rather than a comfortable one. Procedurally, serial scores every 30 to 60 minutes are how I will brief the receiving team and the flight crew, because the trajectory matters to them as much as the snapshot. A deterioration of 4 points or more, or a drop in consciousness is my defined trigger to call the network straight back and escalate retrieval priority.
There is a detail buried in the history you have not touched. His wife mentions, almost as an afterthought, that last Tuesday he described a fuzzy patch in his left vision that cleared in 20 minutes.
That is a transient ischemic attack, and almost certainly a retinal one, what the textbooks call amaurosis fugax. A 20-minute curtain of visual loss in a 74-year-old smoker with diabetes and hypertension is transient monocular blindness until proven otherwise. It was a warning shot fired 6 days before the main event, and it was ignored. That single sentence will organize his entire secondary prevention when we get there, and I am writing it in the notes now with the date and duration.
It also quietly changes how I hear his current deficit. Same left visual field territory. This may be the same vessel declaring itself twice.
Exactly the instinct the examiners reward. 2 events in one vascular territory points at carotid disease until imaging says otherwise, and carotid disease has a surgical fix whose value decays by the day. Park that. It becomes the centerpiece of the back half of this episode.
So, 7:40 in the morning, glucose checked, scored, called the stroke network, booked the aircraft, blood pressure threshold written down. What are you actually doing for him in the next 3 hours? And I want the full answer, because the flight is not landing till after 10.
The next 3 hours are not dead time, and treating them as a waiting room is the mistake that fails candidates. Everything I do now is either protecting the penumbra or preventing the secondary insults that convert salvageable brain into dead brain. Oxygen only if saturations drop below 94%, because routine oxygen in non-hypoxic stroke does harm, not good. Temperature below 37.5, glucose held between 4 and 10, head of bed up around 30 degrees. His perindopril and indapamide are withheld this admission.
He is asking for a cup of tea and his morning tablets. His wife is holding the cup.
And that cup is the most dangerous object in the room. Up to half of stroke patients have some swallowing impairment, and aspiration pneumonia is a preventable complication that kills more stroke patients than people expect. Nil by mouth, including his tablets, until a nurse-led swallow screen is passed. If he fails the screen, his perindopril goes a different route or simply waits, and the fluids he needs come in a drip normal saline, avoiding dextrose.
Name your delegation. You cannot be the doctor, the nurse, the clerk, and the family liaison simultaneously.
The nurse in charge owns the observation schedule and the swallow screen. A second nurse owns Jean, because a 71-year-old wife who has just driven her husband to hospital with a stroke is herself a patient today, and I will book her a GP appointment this week whatever else happens. The ward clerk owns the flight paperwork and the imaging requests the receiving center wants faxed ahead. I own the clinical decisions, the network calls, and the documentation of every timestamp, because last known well, door, call book booking and wheels up are the skeleton of the handover.
It is now 8:50. The phone rings, and it is the retrieval coordinator with weather at your airstrip. Fog. Clearing not before midday. The aircraft cannot land for another 3 hours beyond plan. 6 hours from now, at best, this man reaches a scanner. What happens to Alistair in those 6 hours?
And the interim plan stops being the supporting act and becomes the treatment. And the first thing I recheck is not his blood pressure, it is his swallow, because 6 hours of nil by mouth in a diabetic demands a proper plan, not a default.
6 hours of fog. Walk me through the swallow decision first, then the whole bag of interim care, because this is the stretch of the scenario where candidates go quiet.
The swallow screen happens now. Formally, nurse-led, sips of water, against a checklist of voice quality, cough, and drooling. If he passes, he eats upright with supervision, and his morning tablets can go in. If he fails, he stays nil by mouth, and I put in maintenance fluids calculated for 6 hours, not 2, with his diabetes in mind. Normal saline, no dextrose. Hourly glucose checks while he is off food, and his metformin is held anyway, because a contrast scan at the far end makes that the safer sequence.
Pressure areas, bladder, clot prevention, the unglamorous 3.
Regular turning and a documented skin check every 2 hours, because an elderly man with a dense hemiparesis on a hard emergency trolley develops ulcers in hours, not days. No catheter unless he retains, and I check after 4 hours with a bladder scan rather than defaulting to one, because catheters bring infection into a patient about to face a stroke unit. Clot prevention, he is at high risk, but with an unexcluded intracranial haemorrhage, I do not start heparin prophylaxis. That is a decision I write down explicitly with the reason so nobody upstream reads silence as an oversight.
John is in the corner on her second cup of machine coffee. It is now 11. What does she get told? By whom? On what schedule?
A named nurse owns her, and the promise is specific. An update every half hour even when the news is no news. When I speak to her myself, I use the same 3-part frame every time. What is happening in his brain, what we are doing about it, and what happens next with times attached. And I tell her the truth about the fog rather than a comfortable vagueness, because in a town of 4,000 people she will hear the real story from the airstrip anyway.
Midday. The fog lifts, the aircraft is retasked, and at 1 in the afternoon he is wheels up. Hand over the patient to the flight crew out loud, the way you would say it.
Alistair, 74, ischemic stroke presumed, last known well 22:45 yesterday, deficit onset on waking at 06:50, severity 9 on arrival, 11 and stable since 8:40. Glucose 7s, pressure has run 170 to 195 without crossing my tree threshold. Passed the swallow screen at 9. Nil abnormal on the chest film. No anticoagulant. Metformin held. Routine meds withheld. Wife Jean traveling behind by road. Contact number on the form. Receiving team pre-alerted. Scan booked on arrival.
Identity, situation, background, assessment, recommendation, all in 40 seconds with the timestamps carrying the load. That is the standard. Now he lands. Paint the receiving center picture, because the candidate has to know what happens after they hand over.
Straight to CT. If it shows blood, the pathway becomes the haemorrhage protocol. Pressure lowered to a systolic target of 130 to 140 within the hour. Reversal thinking if he had been anticoagulated, and neurosurgical consultation. If it shows ischemia, the clock question gets asked one last time. Midpoint of sleep, roughly 3 in the morning, puts him near enough to the extended window that the receiving team will at least run the perfusion scan. If that shows a mismatch, tenecteplase 0.25 milligrams per kilogram is on the table. If the perfusion picture is matched and complete, it is not, and no one should push it.
And if a large vessel is blocked on the angiogram?
Clot retrieval enters the conversation, but only at a center with the intervention team, which in Victoria means the Metropolitan Services. The regional hospital stabilizes, images, treats with drug or not, and retriages onward. For our purposes, the lesson is the same as the medication one. Know the whole chain, control only your link.
Blood pressure after thrombolysis. If he gets the drug, what does the stroke unit do for the next 24 hours that your small hospital nurses would be asked to mirror if he bounced back?
Pressures every 15 minutes for 2 hours, every 30 minutes for 6, then hourly through to the 24. Neurological observations hourly. Any sudden drop in consciousness or 4-point deterioration triggers an urgent repeat scan for bleeding into the infarct, and the unit holds fresh frozen plasma and cryoprecipitate pathways ready. Aspirin waits a full 24 hours after the drug, then only if the repeat scan is clean.
Now the part the examiners love more than the thrombolysis. He survives the deficit plateaus at moderate, and in a week he is back in your general practice in Stampsville. The fuzzy vision from last Tuesday is on your desk. Build his secondary prevention, drug by drug, decision by decision.
Antiplatelets first. A high-risk transient ischemic attack or minor stroke gets dual therapy, aspirin plus clopidogrel, started within 24 hours of diagnosis, held for 3 weeks, then step down to one agent for life because long-term dual therapy bleeds more without preventing more. Statin, high intensity, atorvastatin 80 milligrams a day. Blood pressure. The guideline line is simple and sayable. Anyone with stroke or transient attack running above 140/90 in clinic gets therapy started or intensified before discharge, not at some hypothetical later review.
The carotid question. Same territory twice.
That is why the history is the investigation. 2 events in the left eye and left hemisphere territory puts the right carotid at the head of the queue. He needs carotid imaging, and the guideline gives the window, at initial assessment if possible, never delayed past 2 days. If it shows a 70% stenosis on the right and he is fit for surgery, the endarterectomy should happen inside 2 weeks of the event, because the operative benefit shrinks month by month. 2 events ago that window was open with a bang. Today it is closing, and that is the quiet tragedy of the ignored warning.
Rhythm. He still has no explanation.
Then he gets the monitor. ECG today, and if nothing, a patch or halter for a week, because paroxysmal atrial fibrillation hides, and its discovery changes his therapy from antiplatelets to anticoagulants outright. Add the lifestyle layer said plainly. 45 pack years, so cessation support with real pharmacotherapy, not a pamphlet. Diabetes review. And his blood pressure tablets, the ones I withheld for 2 days, are restarted and intensified against the 140 target.
He drives, or drove, a country town with no bus.
This is where rural medicine gets concrete. After a stroke, no private driving for a minimum of 4 weeks, longer if deficits persist, and commercial licenses 3 months. After a transient ischemic attack alone, 2 weeks private, 4 commercial, no conditional license needed. My obligations are threefold. Tell him in plain words, write it in the notes and in a letter he takes home, and know that the licensing authority notification rules sit behind the advice. Jean has been the taxi this whole fortnight, which is exactly why her health, her eyes, and her own GP visit are on my list, not an afterthought.
Follow-up architecture. Every result that exists or will exist, and who owns it.
The carotid scan result is owned by the regional stroke service before discharge with a copy to me. The rhythm monitor result likewise, formal bloods couriered on the thrice-weekly run, owned by me until I have seen and actioned them. A GP visit inside 7 days of discharge booked before he leaves hospital, not advised. Practice nurse pressure check at 2 weeks. Jean's own appointment this week, and a recall call at 2 weeks to confirm the whole stack landed. Tablet, picture, pressure, plan.
Now the examiner's structured lens. The 3 things a candidate must say on a stroke station in a CT-less town in order.
1. Last known well time, not door time, drives every decision, and I state it in the first minute. 2. No imaging, no thrombolysis. The safe answer is organized transfer plus specialist contact plus disciplined interim care, and I say that as system design, not apology. 3. Secondary prevention starts on day 1, with the carotid window and the driving rules as hard clocks with dates attached.
And the trap answers that fail candidates.
Giving a thrombolytic without a scanner on the logic that something is better than nothing. That fails. Quoting 4.5 hours from arrival instead of last known well. That fails. Dropping the pressure to normal because the number looks scary. That fails. And discharging the transient attack with reassurance and no imaging plan. That fails hardest because it is the error that created this week.
For the recap, the 2 embedded reviews. 7 days ago, the young man in behavioral crisis at 2 in the morning. You built it on Queensland law that day. Rebuild the legal spine for Victoria out loud.
The framework is the Mental Health and Wellbeing Act 2022. Police or an authorized person who believes a person appears mentally ill and that taking them into care is necessary to prevent imminent and serious harm can detain them under Section 232, and the person must then be examined as soon as practicable. If I examine him and the compulsory assessment criteria hold, I make an assessment order under Section 144. The criteria are fourfold and worth memorizing as a recitation: apparent mental illness, apparent need for immediate treatment to prevent serious deterioration or serious harm, that he can in fact be assessed, and that no less restrictive option is reasonably available.
Say the least restrictive principle as more than a phrase.
It means the involuntary pathway is the last door, not the first. Before it, a quiet low stimulation space, means removed, de-escalation attempted and documented, oral sedation offered before any injection, droperidol 5 to 10 milligrams intramuscularly only if behavior is dangerous, repeated at 15 minutes, 20 milligrams maximum, with a target of drowsy but rousable and a cardiac trace after repeat dosing. The assessment order expires fast. Community 1 day, inpatient within a day of arrival. Extensions only by a psychiatrist and only twice. And before any of it, the clinical must not be forgotten. Glucose, vitals, intoxication, a head injury check.
And the discharge the second time round.
A safety plan written with him before he leaves, not handed to him. Aboriginal health worker linked follow-up, urgent rather than routine mental health review. 13 yarn and lifeline numbers in the plan. And a GP visit inside 72 hours with a named person holding each item.
Yesterday's infant. Next day review. 4 questions. Fast answers. Oxygen threshold.
Persistently below 90% for an infant over 6 weeks without comorbidity, below 92 under 6 weeks or with underlying illness, and never for work of breathing alone.
The do not list.
No salbutamol under 12 months, no steroids, no routine antibiotics, no routine hypertonic saline, no physio, no deep suction, documented as decisions.
Escalation number and trigger.
Pediatric retrieval on 1300-1-37650, called the moment severity declares, high flow only after low flow fails.
Discharge power move.
Nirsevimab before the baby leaves, sibling 2, while the Victorian program window runs to the end of September.
Recap the day in 3 sentences.
Stroke in a scannerless town is a time-stamping exercise wrapped around a physiology bundle, glucose, pressure thresholds, swallow, and the discipline not to treat numbers that do not need treating, the reperfusion knowledge, tenecteplase 0.25 per kilogram, the 4.5-hour standard window, the 9-hour imaging selected extension with the sleep midpoint rule, belongs in your head even when the drug is 300 kilometers away, and the transient attack that was ignored last Tuesday is where the exam marks live. Dual antiplatelets for 3 weeks, carotid imaging inside 2 days, surgery inside 2 weeks, no driving for a month, every follow-up with a name against it.
Tomorrow is day 80. Trauma takes the stage. The multi-injured farmer, your 2 theaters, 4 units of O negative, and the retrieval that will not arrive for hours. Bring your hands as well as your head.
Until then, nail the last known well time, protect the swallow, and write the dates on the carotid clock. This has been Stamps Daily, independent preparation for the fellowship exam. If it helped, pass it to a colleague who is counting down too.